Asthma and chronic obstructive pulmonary disease. Roya, Pleasance 2nd, 41. 830 Chapter 41 I. C. Asthma, definition. Asthma is a chronic inflammatory disorder of the airways. It involves complex interactions between many cells, for example, eosinophils, mast cells, macrophages, and inflammatory mediators, for example, interleukins, leukotriene, that result in inflammation. Obstruction partially or completely reversible after treatment or resolved spontaneously. Increased airway responsiveness, that is, hyperresponsiveness, and episodic asthma symptoms, CI. Neutrophils may play an important role in some asthma exacerbations. B. Classification. Asthma severity classifications according to the 2007 expert panel report of the National Heart, Lung, and Blood Institute (NHLBI) include mild intermittent asthma, in addition to mild, moderate, and severe persistent asthma. Table 41-1. The asthma guidelines highlight that disease severity is used to initiate therapy and asthma control should be used to monitor therapy. The 2007 guidelines have also been modified to incorporate domains of both disease risk and impairment to determine disease severity. The guidelines define impairment as the frequency and intensity of symptoms and functional limitations the patient is currently experiencing or has recently experienced. Risk is defined as the likelihood of asthma exacerbations, progressive decline in lung function, or for children lung growth, or adverse effects from medications. A patient's severity classification plays an important role in determining the most appropriate pharmacotherapeutic approach and is determined by 1. Symptoms. Short-acting agonist use, nocturnal symptoms. 2. Interference with normal daily activity. 3. Lung function, spirometry to determine FeVO2 and FVC. And 4. Frequency of exacerbations. C. Incidence. In 2002, according to CDC data, approximately 31 million Americans had ever been told they had asthma during their lifetime. In 2002, 20 million people in the United States had asthma, 7% of population. 1. It has been estimated that 8.3 million children age 18 years and younger have asthma. 2. Asthma improves in many children as they age. 50% appear to have outgrown asthma by their mid-teens. However, it is incorrect to consider that these individuals no longer have asthma because many eventually have a return of symptoms. 3. 60% of asthmatics have at least one asthma flare each year. 4. Although death from asthma remains uncommon, death rates had been increasing in recent years but appear to have reached a plateau. In 2007, there were 3,447 deaths attributed to asthma. This represents a significant decline since 2000. The most common cause of death is believed to be inadequate assessment of the severity of airway obstruction by either practitioner or patient, leading to suboptimal therapy. 5. The cost to society of asthma is substantial. In 2000 alone, it is estimated that direct costs related to asthma exceeded $8.1 billion. These costs include $2.4 billion for medications and $3.5 billion for asthma and chronic obstructive pulmonary disease. Roya, Pleasance 2nd, 41. 830, Chapter 41, I, C. Table 41-1 Classification of asthma severity. Components of severity. Classification of asthma severity. 12 years of age. Intermittent. Persistent. Mild, moderate, severe. Impairment. Normal FeNO FT years 85%. 20. Normal FeN years 80%. 40s 85 years 75%. 60 years 70%. Symptoms 2 days week, 2 days week, but not daily throughout the day, nighttime awakenings. 2 month, 3, 4 some month, 1 a week, but not nightly. Often 7 week. Short-acting 2 agonists used for symptom. Controlled, not prevention, of EIB. 2 days week, 2 days week. But not daily, and not more than 1 on any day. Daily several times. Per day. Interference with normal activity, none, minor limitation, some limitation, extremely limited. Lung function. Normal FeNO between exacerbations. FeNO 80% predicted. FeNO FVC normal. FeNO 80% predicted. FeNO FVC normal. FeNO 60%, but 80% predicted. FeNO FVC reduced 5%. FeNO 60% predicted. FeNO FVC reduced 5%. Risk. Exacerbations. Requiring oral systemic corticosteroids. 0. 1 year. C note. 2 year. C note. Consider severity and interval since last exacerbation. Frequency and severity may fluctuate over time for patients in any severity category. Relative annual risk of exacerbations may be related to FeNO. Recommended step for initiating treatment: Step 1, Step 2. Step 3, Step 4 or 5. And consider short course of oral systemic corticosteroids. In 2 or 6 weeks, evaluate level of asthma control that is achieved and adjust therapy accordingly. EIB, exercise-induced bronchospasm, FeNO, forced expiratory volume 1C, FVC, forced vital capacity. Adapted from Expert Panel Report 3. Guidelines for the diagnosis and management of asthma. Available online at www.nbLBI.nih.gov/guidelines/asthma/epr/index.htm. Last accessed April 10, 2008. Hospitalizations. Indirect costs of asthma are estimated at $4.6 billion. Acute care visits, for example, hospitalizations account for the majority of healthcare costs for asthma. Key cause. Precipitating factors of an acute asthma exacerbation may include the following. 1. Allergens, for example, pollen, house dust mite, animal dander, mold, cockroaches, food. A. Concurrent predisposition to allergy is highly prevalent in patients with asthma, especially children. B. For example, allergic rhinitis is reported in 45% of patients with asthma compared to 20% of the general population. 2. Occupational exposures. For example, chemical irritants, flour, wood, textile dusts. 3. Viral respiratory tract infections. 4. Exercise. 5. Emotions, for example, anxiety, stress, hard laughter, crying. Asthma and chronic obstructive pulmonary disease. 831. 6. Exposure to irritants, for example, strong odors, chemicals, fumes. 7. Environmental exposures, for example, weather changes, cold air, sulfur dioxide, cigarette smoke. 8. Drugs. Reactions to drugs may occur as a result of hypersensitivity or as an extension of the pharmacological effect. B. Problematic drugs include 1. Aspirin and other nonsteroidal anti-inflammatory drugs such as ibuprofen. Note: cyclooxygenase 2 inhibitors are not recommended for use in aspirin-sensitive asthma patients. Antiadrenergic and cholinergic drugs, for example, adrenergic blockers, bethanyl, 3 medications or foods that contain tartrazine, sulfites, benzalkonium chloride, and other preservatives. Excipients in inhaled drugs that are derivatives of legumes, soybeans, in peanut allergic patients, for example, oleic acid. E. Pathology. On postmortem examination of patients with asthma, the following characteristics have been identified. 1. Hypertrophy of smooth muscle. 2. Airways containing plugs consisting of inflammatory cells and their debris, proteins, and mucus. 3. Inflammatory cellular infiltrate with vasodilation, denuded airway epithelium, and microvascular leakage. 4. Vasodilation of the vasculature. 5. Denuded airway epithelium. 6. Microvascular leakage. 7. Collagen deposition in basement membranes. F. Pathophysiology, figure 41-11. Major contributing processes: inflammatory cells, that is, mast cells, eosinophils, activated T cells, macrophages, and epithelial cells, secrete mediators and influence the airways directly or via neural mechanisms. Figure 41-1. The Pathophysiology of Asthma. 832, Chapter 41 I. F. B. Airway obstruction is responsible for many of the clinical manifestations of asthma. 1. Severity of obstruction is variable and believed to be a result of bronchoconstriction, airway wall edema, mucus plug formation, airway remodeling, smooth muscle hypertrophy, and hyperplasia. 2. Airway obstruction reduces ventilation to some lung regions, which causes a ventilation perfusion VC imbalance that leads to hypoxemia. This is reflected by a reduction in the partial pressure of arterial oxygen, CO2, observed in moderate to severe exacerbations. C. Hyperresponsiveness, an exaggerated response to certain stimuli, is an important feature of asthma and appears to correlate with clinical severity and medication requirements. Increased levels of inflammatory mediators and infiltration by inflammatory cells are thought to be the primary mechanisms responsible for airway hyperresponsiveness. D. Airway inflammation is crucial to development of asthma and contributes to airway hyperresponsiveness, airflow obstruction, respiratory symptoms, and disease chronicity. Inflammatory cells and their mediators are responsible for altered mucociliary function, epithelial disruption ranging from minor ciliary loss to severely denuded epithelium, increased airway permeability to inhaled allergens, irritants, and inflammatory mediators, and reduced clearance of inflammatory mediators. 1. Acute inflammation is associated with early recruitment of cells to the airway. Subacute Subacute inflammation is associated with recruited and resident cell activation, resulting in more persistent inflammation. 3. Chronic inflammation is associated with persistent cell damage and ongoing repair, resulting in airway abnormalities that may become permanent. Alteration in autonomic neural control also contributes to obstruction. 1. Elevated parasympathetic tone and reflex bronchoconstriction may occur as a result of increased cholinergic sensitivity or a change in muscarinic receptor function. Increased smooth muscle responsiveness may be the result of smooth muscle hypertrophy. Exposure of the nerve endings caused by inflammation may also contribute. F. Airway remodeling can result from persistent inflammation to chronic asthma. The resulting damage can yield permanent airway abnormalities because of subbasement membrane collagen deposition and fibrosis. Hypertrophy of the airway smooth muscle is another form of tissue remodeling in asthma. These events may occur even in the face of mild disease, but airway remodeling does not necessarily occur in all asthma patients. 2. Sequencing of events in asthma. Triggering. In an allergic asthma patient, after exposure to an allergic trigger, the antigen binds to immunoglobulin E, which is attached to activated mast cells. Non-allergic factors, for example, aspirin, viral infections, may also function as triggers. Viral infections serve as an important cause of worsened asthma. B. Early and late responses. 1. The early asthmatic response begins within 30 minutes of trigger exposure, usually only several minutes after exposure, and resolves within 2 HRs. This results in constriction of the airway smooth muscles, bronchospasm, and subsequently asthma symptoms. This response can be blocked by the administration of short-acting agonists, albuterol, ProAir, Ventolin, Proventil, Perbuterol, Maxair, or levobuterol, Exopinex. 2. The late asthmatic response involves a second decline in lung function, typically 4 to 8 HRS after the initial trigger exposure. The early asthma response does not necessarily progress into the late asthmatic response. The late asthmatic response, principally an inflammatory response, is characterized by persistent airflow obstruction, airway inflammation, and bronchial hyperresponsiveness. The response may last several days, and bronchial hyperreactivity may persist for several weeks. This response can be blocked by the administration of corticosteroids, inhaled steroids such as budesonide, Pulmicort, and leukotriene modifiers such as montelukast singulaire, or chromones, that is, netochromoltilade. G. Clinical Evaluation 1. Physical findings. In asymptomatic patients, physical findings of asthma are often not present. B. Physical findings depend on the severity of the underlying disease and the severity of the exacerbation. Regardless of the underlying disease severity, patients can have mild, moderate, or severe exacerbations. Table 41-2. Asthma and chronic obstructive pulmonary disease 833. Table 41-2 Stages of severity of an acute asthmatic attack. Stage symptoms Favone or FVC arterial pH PaO2 PaCO2. I mild breathlessness while 70% of normal or walking, speaks in sentences, moderate wheezing. Moderate dyspnea while at rest in 40%, 69% of normal 60 megameters Hg 42 megameters Hg. Phrases, loud wheezing throughout expiration. There is severe breathlessness while at 40% of normal or 60 megameters, Hg 42 megameters. Rest. Speaks in words loud wheezing, coughing, difficulty speaking, accessory chest muscle use, and chest hyperinflation. IV respiratory severe respiratory distress, 25% of normal failure confusion lethargy, cyanosis disappearance of breath sounds, and pulsus paradoxus 12 megameters Hg. Favone, forced expiratory volume in 1 SEC, FVC, forced vital capacity, PaO2, partial pressure of arterial oxygen, PaCO2, partial pressure of arterial carbon dioxide, increased, decreased, markedly increased, markedly decreased. C. Patients with chronic, poorly controlled, severe asthma may have evidence of chronic hyperinflation, including barrel chest and decreased diaphragmatic excursion, similar to chronic obstructive pulmonary disease. D. Acute exacerbations may have a sudden or gradual onset. Symptoms are frequently nocturnal or occur in the early morning hours. 1. Common findings in an acute exacerbation include shortness of breath. Wheezing usually occurs at the end of exhalation, but may be heard throughout inspiration and exhalation in more severe asthma. C. Chest tightness. D. Cough. E. Tachypnea and tachycardia, moderate to severe exacerbations. If pulsus paradoxus, severe exacerbations. 2. Between acute asthma exacerbations, the patient may be asymptomatic. 2. Diagnostic test results. A pulmonary function test determine the degree of airway obstruction and may be normal between exacerbations. The 2007 NHLBI asthma guidelines recommend spirometry in all asthma patients 5 years old to determine that airway obstruction is at least partially reversible. Breathing tests include spirometry and peak flow meter testing. 1. Forced expiratory volume in 1 second, Favone and forced vital capacity, FVC, both decrease during an acute exacerbation. The spirometer is used to generate the Favone and FVC, a residual volume, or V, in total lung capacity. Meiosis in asthma because of air trapping and subsequent lung hyperinflation. 3. Peak expiratory flow rate, PFR, obtained through the patient forcefully breathing out into a peak flow meter, correlates well with Favone. However, PFR measurement is not used in making the diagnosis of asthma. PFR measurement can be used to monitor control of asthma. A. Uses of PFR monitoring at home include assessment of therapy, trigger identification, and assessment of the need for referral to emergency care. 834 Chapter 41I. G. E. PFR monitoring at home is recommended for patients who have had severe exacerbations, who are poor perceivers of asthma symptoms, and who have moderate to severe disease. C. PFR is best measured in early morning, before medication administration. More F. Frequent monitoring over a few weeks may also be indicated to identify specific patterns and to identify a patient's personal best PFR measurement. In this case, measurements are taken before medications are taken in the morning, that is, on awakening. 4. Provocation testing with histamine or methacholine challenge may be performed to assess hyperresponsiveness and to rule out asthma in a patient who has had normal pulmonary function tests, whom asthma is still suspected. B. Blood analysis, although not typically undertaken in asthma, typically shows a slightly increased white blood cell WBC count during an acute exacerbation. Eosinophilia also may be present. Leukocytosis may be present because of WBC demargination that occurs when patients receive systemic corticosteroids. C. Pulse oximetry is a non-invasive means of assessing the degree of hypoxemia during an acute exacerbation. The oximeter measures oxygen saturation in arterial blood, O2 and pulse. D. Arterial blood gas measurements may be required to help gauge the severity of the asthma exacerbation. Table 41-2. 1. In the early stages of an asthma exacerbation, hyperventilation results in a decrease in the partial pressure of arterial carbon dioxide, PaCO2. If the exacerbation progresses and the airways remain narrowed, respiratory muscles may fatigue and the PaCO2 level increases. 2. Respiratory acidosis is a poor prognostic sign. It develops if hypoxemia worsens and the patient's respiratory rate is not maintained owing to respiratory fatigue. This results in a rising PaCO2 level. An electrocardiogram (ECG) may show sinus tachycardia. An ECG may be particularly useful in an older patient. A chest radiograph may be normal or could detect accompanying pneumothorax, atelectasis, or pneumonia. Evidence of hyperinflation may be present in acute asthma and in chronic, poorly controlled asthma. A chest radiograph may also be needed to exclude other causes of the patient's symptoms. 3. Signs of respiratory distress include A. Use of accessory muscles. B. Inability to speak in sentences or ambulate owing to dyspnea. C. Declining mental status. D. PEFR 50% of predicted are personal best. E. Cyanosis. F. Suprasternal retractions. G. Absence of respiratory sounds. H. Increasing PaCO2. And I. Unable to sleep for extended time because of shortness of breath. 4. Patients with potentially fatal asthma should be quickly identified and aggressively managed. These patients have the following characteristics. A. History of severe exacerbations. P. Particularly exacerbations that develop suddenly. B. Poor self-perception of asthma symptoms and severity. C. History of intubation or intensive care unit (ICU) admission for asthma. D. 2 or more hospitalizations, or 3 or more visits to the emergency department for asthma within 1 year. E. Hospitalization or treatment in the emergency department for asthma within the last month. F. Frequent agonist use, that is, more than 2 canisters per month. Current systemic steroid treatment or recent systemic steroid withdrawal. G. Concurrent conditions, for example, cardiovascular or psychiatric disease, substance abuse. Low socioeconomic status, particularly in urban areas. H. Therapy. 1. Treatment objectives. The goal of therapy is to provide symptomatic control with normalization of lifestyle and to return pulmonary function as close to normal as possible. Asthma and chronic obstructive pulmonary disease 835. B. The treatment goals listed in the 2007 NHLBI's Expert Panel Update Report include the following. 1. Reduce impairment. A. Prevent chronic and troublesome symptoms day or night. B. Maintain normal pulmonary function. Maintain normal activity levels, including exercise and attendance at work or school. D. Minimal use of short-acting inhaled 2 agonist, less than 2 times per week, for quick relief of symptoms, not including use prior to exercise. E. Meet patient and family expectations. To reduce risk, prevent recurrent exacerbations and minimize need for ED visits or hospitalizations. B. Prevent loss of lung function. C. Provide optimal pharmacotherapy and with minimal or no adverse effects from medications. 2. Management of acute asthma exacerbations. A. Home-based treatment of an acute asthma exacerbation. Figure 41-2. B. Treatment of an acute asthma exacerbation in the hospital or emergency department. Figure 41-3. Management of persistent asthma. A stepwise approach to pharmacological therapy is recommended to gain and maintain control of asthma in both the impairment and risk domains. Table 41-3. The type, amount, and scheduling of medication is dictated by asthma severity for initiating therapy and the level of asthma control for adjusting therapy. B. At each step, patients should control their environment to avoid or control factors, when possible, that make their asthma worse, for example, allergens, irritants. This requires specific diagnosis and education. C. Inhaled steroids are considered to be first-line anti-inflammatory agents in asthma. D. Combination products for asthma are formoterol budesonide, Symbicort, fluticasone salmeterol, Advair, and mometasone formoterol, Dulera. These products are indicated for moderate or severe persistent asthma. The 2007 NHLBI asthma guidelines give equal weight to increasing the dose of the inhaled steroid, compared to adding a long-acting 2 agonist to the inhaled steroid in uncontrolled chronic asthma. In the United States, Advair is available as metered dose inhalers, MDS, and dry powder inhalers, DPIZ, Discus. Symbicort is available as an NDI. Inhaled agonists such as albuterol and levobuterol are used as needed for acute symptoms for all levels of severity. 1. Daily or increasing use of a short-acting inhaled 2 agonist suggests the need for additional long-term controller. That is, anti-inflammatory therapy. 2. Pretreatment with either an inhaled agonist, montelukast, or natochromyl may be used before exercise or allergen exposure. F. A rescue course of systemic corticosteroid, for example, prednisone, may be needed at any time and at any step. 4. Prevention and treatment of exercise-induced bronchospasm, EIB. Steps to prevent EIB should be implemented in all patients with asthma. B. Patients should be advised that a warm-up period might be helpful in preventing EIB. C. EIB can usually be prevented with one of the following options. 1. Short-acting agonists, for example, albuterol should be administered 15 mins before exercise. These are considered the drug of choice for EIB. 2. Long-acting agonists, salmeterol, Servant, and formoterol, Fordil, should be administered 30 to 60 mins before exercise. When salmeterol is used chronically for EIB, some patients may lose protection toward the end of the 12-HR dosing interval. Because of its rapid onset, formoterol may be dosed 15 mins before exercise. Generally, short-acting agents are preferred over long-acting agonists. Natochromyl may be used to prevent EIB and exacerbations related to exposure to other asthma triggers. Natochromyl should be administered no more than 1 HR before exercise or exposure. 4. Leukotriene modifiers given daily help with EIB, but should not be used on an as-needed basis just before exercise. 836 Chapter 41I H.D. Regardless of the prophylactic approach, all patients who experience EIB should have a short-acting agonist available for treatment of breakthrough symptoms. 5. Concurrent diseases allergic rhinitis, sinusitis, and gastroesophageal reflux disease, GERD, frequently coexist with asthma. Other notable comorbidities in asthma include vocal cord dysfunction, VCD, and obstructive sleep apnea. B. GERD is frequent in persons with obstructive lung disease. Management of GERD with proton pump inhibitors, PPEs such as pantoprazole, Protonix, can improve asthma symptoms and, in some patients, breathing tests. H2 antagonists, such as ranitidine, Zantac, are less effective than PPIs in this situation. C. Asthma control has been shown to improve if these conditions are adequately controlled. Assess severity. Measure PEF, value 50% personal best, or predicted suggests severe exacerbation. Note signs and symptoms, degrees of cough, breathlessness, wheeze, and chest tightness correlate imperfectly with severity of exacerbation. Accessory muscle use and suprasternal retractions suggest severe exacerbation. Initial treatment. Inhaled short-acting 2 agonist, up to 3 treatments of 2-4 puffs by MDI at 20 minutes intervals or single nebulizer treatment. Good response. Mild episode. PEF 80% predicted or personal best. No wheezing or shortness of breath. Response to 2 agonists sustained for 4 HRs. May continue 2 agonists every 3-4 HRs for 24-48 HRs. Contact clinician for follow-up instructions. Incomplete response. Moderate episode. PF 50%, 80% predicted or personal best. Persistent wheezing and shortness of breath. Add oral corticosteroid. Continue 2 agonist. Contact clinician urgently this day for instructions. Poor response. Severe episode. PF 50% predicted or personal best. Marked wheezing and shortness of breath. Add oral corticosteroid. Repeat 2 agonist immediately. If distress is severe and non-responsive, call your doctor and proceed to emergency department. Consider calling ambulance or 911. Proceed to emergency department. Figure 41-2. The NIH treatment algorithm for the home-based management of asthma exacerbations. National Institutes of Health, U.S. Department of Health and Human Services. NIH highlights of the expert panel report 3. Guidelines for the Diagnosis and Management of Asthma. 2007. Figure 5-4. NIH publication A-4051. Asthma and chronic obstructive pulmonary disease 837. Figure 41-3. NIH treatment algorithm for management of asthma exacerbations in the emergency department and hospital. Favone. Forced expiratory volume in 1 cc. PEF. Peak expiratory FLO. PCO2. Partial pressure of carbon dioxide. From National Institutes of Health, U.S. Department of Health and Human Services. NIH highlights of the expert panel report 3. Guidelines for the Diagnosis and Management of Asthma. 2007. Figure 5-6. NIH publication 08-4051. Initial assessment. History, physical examination, auscultation, use of accessory muscles, heart rate, respiratory rate, PF or Favone, oxygen saturation, and other tests as indicated. Favone or PF 40% inhaled 2 agonists by metered dose inhaler or nebulizer. Up to 3 doses in the first hour. Oxygen to achieve O2 saturation 90%. Oral systemic corticosteroids if no immediate response or if patient recently took oral steroid. Moderate exacerbation. Favone or PF 40%. 69% predicted personal best physical exam. Moderate symptoms. Short-acting 2 agonist every 60 mins systemic corticosteroid. Continue treatment 1, 3 HRS, provided there is improvement. Good response. Favon or PF 70% response sustained 60 mins. After last treatment, no distress. Physical exam. Normal. Discharge home. Continue treatment with inhaled 2-agonist course of oral systemic corticosteroid. Patient education. Review medicine use. Review with initiate action plan. Close medical follow-up. Admit to hospital ward. Inhaled 2-agonist inhaled anticholinergic. Systemic corticosteroid oral or intravenous oxygen. Monitor Favon or PF. O2 saturation, pulse. Discharge home. Continue treatment with inhaled 2-agonist course of oral systemic corticosteroid. Patient education. Review medicine use. Review with initiate action plan. Close medical follow-up. Improve. Admit to hospital intensive care inhaled 2-agonist hourly or continuously inhaled anticholinergic. Intravenous corticosteroid oxygen. Possible intubation and mechanical ventilation. Poor response. Favon or PF 50% PCL2 42 mmHg. Physical exam. Symptoms severe, drowsiness, confusion. Incomplete response. Favon or PF 50% but 70% mild to moderate symptoms. Individualized decision re. Hospitalization. Severe exacerbation. Favon or PF 40% predicted personal best physical exam. Severe symptoms at rest. Accessory muscle use. Chest retraction history. High-risk patient. No improvement after initial treatment. Inhaled short-acting 2-agonist. Hourly or continuous inhaled anticholinergic oxygen. Systemic corticosteroid. Repeat assessment. Symptoms. Physical examination. PF. O2 saturation. Other tests as needed. Impending or actual respiratory arrest. Intubation and mechanical ventilation with 100% O2 nebulized 2-agonist and anticholinergic. Intravenous corticosteroid. Admit to hospital intensive care. Favon or PF 40%. Severe exacerbation, inhaled high-dose 2-agonist, and anticholinergic by nebulization every 20 mins or continuously for 1 HR oxygen to achieve O2 saturation 90%. Oral systemic corticosteroid. 838, Chapter 41I. H. Table 41-3 medications recommended for long-term control of asthma. Step age 0. 4 years to age 5, 11 years to age 12 years B. 1. Intermittent short-acting inhaled 2-agonist taken asthma. 2-agonist taken as 2-agonist taken as needed to treat symptoms. Short. Needed to treat acting inhaled 2-agonist, cromolyn. Symptoms or nitochromyl taken shortly before. Exercise in patients known to have exercise-induced bronchospasm. Or sustained montelukast is an antagonist, nitochromyl. Release theophylline. 3. Or 3 per 1. Persistent inhaled corticosteroid is an but not preferred. Or sustained montelukast is an antagonist, nitochromyl. 3. Or sustained montelukast is an antagonist, nitochromyl. Release theophylline is an alternative, but not, or theophylline is an but not preferred alternative. 3. Persistent inhaled alternative, but not preferred receptor. 3. Persistent inhaled corticosteroid, low inhaled corticosteroid, low dosage and asthma, medium dosage, plus long-acting 2 agonist, or inhaled 2 agonist, leukotriene corticosteroid, medium dosage, receptor antagonist, or inhaled corticosteroid, low dosage, theophylline, or inhaled plus either leukotriene receptor corticosteroid, medium antagonist, theophylline, or Xylitol dosage, is an alternative, but not P. Acting 2 agonist or inhaled medium dosage, acting 2 agonist or inhaled corticosteroid leukotriene receptor antagonist, montelukast, medium dosage, plus theophylline, or Xylitol as in either leukotriene, alternative, but not preferred receptor antagonist, or theophylline is an alternative, but not preferred. For patients with 2 agonist or corticosteroid, high sensitivity to relevant perennial montelukast dosage, plus either allergens leukotriene receptor antagonist or theophylline is an alternative, but not preferred. 6. Persistent inhaled corticosteroid, high inhaled corticosteroid, high dosage, asthma, high dosage and dosage, oral systemic corticosteroid, and long-oral systemic corticosteroid, and long-acting 2 agonist, omalizumab may be. Corticosteroid plus acting 2 agonist, considered for patients with sensitivity, either long-acting inhaled corticosteroid to relevant perennial allergens 2 agonist or high dosage and oral montelukast systemic corticosteroid plus either leukotriene receptor antagonist or theophylline is an alternative, but not preferred. For all 6 steps, a short-acting 2 agonist should be used as needed to relieve symptoms of asthma. For all 6 steps, a short-acting 2 agonist, up to 3 treatments at 20-minute intervals, should be used as needed to relieve symptoms of asthma. Short-course therapy with an oral systemic corticosteroid may be needed. Adapted from Expert Panel Report 3. Guidelines for the Diagnosis and Management of Asthma. Available online at www.nhlbi.nih.gov/guidelines/asthma/epr/index.htm. Last accessed April 10, 2008. Asthma and chronic obstructive pulmonary disease 839. First therapeutic agents. 1. Agonists: albuterol, formoterol, arformoterol, levobuterol, metoprolol, metoprolol, peer. Buterol, salmeterol A. Short-acting agonists: albuterol, levobuterol, pyrbuterol, metoprolol are best reserved for worsening symptoms, treatment of acute exacerbations, and prophylaxis for EIB. Assessing the frequency of short-acting agonist use for rescue therapy can help determine the patient's level of asthma control. Those requiring regular use, for example, every day, of short-acting agonists have uncontrolled disease and should receive more aggressive controller therapy. B. Indications for long-acting agonists. Maintenance treatment of moderate and severe persistent asthma in combination with inhaled corticosteroids, particularly for patients with frequent nocturnal symptoms. A. Long-acting 2 agonists, salmeterol, formoterol, or formoterol, should not be used as sole therapy for an acute asthma exacerbation in lieu of short-acting agents. B. Research indicates that rather than increasing the dose of the inhaled corticosteroid in uncontrolled chronic asthma, adding a long-acting agonist results in a greater improvement in symptoms and breathing tests. C. Recent warnings have been placed in the package inserts for long-acting 2 agonists regarding an increased risk of asthma death. This has led to the 2007 NIH asthma guidelines giving higher priority to increasing the dose of inhaled steroids as compared to adding a long-acting 2 agonist to current inhaled steroid dose to manage uncontrolled chronic asthma. There are box warnings in the package insert for these drugs. Prophylaxis of EIB, pre-patients with asthma and concurrent chronic obstructive pulmonary disease, COPD. C. Therapeutic effects. These sympathomimetic agents relieve bronchoconstriction during acute asthma exacerbations, as well as during chronic therapy, and prevent exacerbations from occurring during exercise. D. Mechanism of action. 1,2 agonists stimulate 2 receptors, activating adenyl cyclase, which increases intracellular production of cyclic adenosine monophosphate, CAMP. A. Increased intracellular CAMP and activation of CAMP results in bronchodilation, improved mucociliary clearance, and reduced inflammatory cell mediator release. B. Stimulation of 2 receptors in skeletal muscle accounts for tremor. Agonists differ in their affinity for the 1 and 2 receptors. Agents with greater 1 receptor affinity are more likely to cause cardiac effects. E. Administration and dosage. Whenever possible, agents should be administered via inhalation to minimize systemic exposure and adverse reactions. Systemic administration should be reserved for patients who cannot use inhalation therapy. 2. Regimens with long-acting 2 agonists should also include a concurrent inhaled corticosteroid, unless it is being used only to prevent EIB. All regimens containing long-acting agents should also include a short-acting agent for treatment of acute symptoms. 3. Dosage information is provided in Table 41-4. F. Precautions and monitoring effects. 1 common adverse effects of agonists include tremor, palpitation, tachycardia, nervousness, and headache. Leg cramps may occur with high doses owing to hypokalemia. Non-sucral selective agonists, for example, isoproteinol, asuprol, may induce myocardial ischemia, myocardial necrosis, and arrhythmias because of excessive cardiac stimulation. Use of 2 selective agents, for example, albuterol, bisoltrol, is preferred. Tachyphylaxis, form of tolerance, can occur with regular use of inhaled or oral agonists. Suggested mechanisms include a decrease in the number of active receptors owing to movement of receptors from the cell surface into the cell, downregulation, b. a decreased sensitivity in the receptors to stimuli, making them unable to activate adenyl cyclase. The clinical significance of this effect is unclear with normal doses of agonists. This effect may be lessened by adding corticosteroids to the regimen. 840 Chapter 41, 1a. Table 41-4. Adrenergic agonists used in the treatment asthma, or COPD, severe acute, chronic, agent, pediatric, adult, site of action, duration of action, comments, albuterol neb 0.5%. Et 255 mg. Not currently. 1 receptors, 3 8HRs. May mix with 5 GZML minimum. 2.5 milligrams Q20 mins recommended. 2 receptors. Inhalation. Cromolyn, or Q20 mins 3 doses, then 4 8HRs oral. Ipratropium NEB, then 0.15, 0.30, 2.5, 10 mg, may double, mg kg, up to Quan 4 HRs P R, or dose for mild 10 mgq 1 for HRSPRN 10 15 mg exacerbations, or 0.5 ng akg hr continuously QR 1.25 mg QR 0.05 mg in 2-3 ml saline minimum 1.25 milligrams Q4 8 HRS maximum 2.5 milligrams in 2-3 ml saline Q4 HRS MDI 0.09. It's 4-8 puffs. It's 4-8 puffs. Not currently. MG puff Q20 mins 3 doses Q mins. Up. Recommended. Then Quan 4 HRS with to 4 HRS. Then spacer Quan 4 HRS P R N QR2 puffs QR2 puffs T A Q P R N T E Q 1 2 puffs 5 mins PT 2 puffs 5 mins before exercise oral 4 not currently 0.3 pre 6 min or Nulvh sustained recommended day maximum release 8 mg day bilateral neb 0.2% at 0.15 mg 255 mg not currently 1 receptors 6 8 HRs dilute neb with 2 by 3 G minimum 2.5 milligrams Q20 mins 3 doses recommended 2 receptors ml normal saline Q20 mins 3 doses, then 2.5 10 mg. Do not mix. Neb. Then 0.15 0.30. Con 4 HRs P in or with other neb mg kg up to 10 milligrams 10 15 mg HR solutions con 4 HRs PRN or continuously thought to be about 0.5 mg kg keyword 0.535 mgn. Cafes potent as continuously 2-3 milliliters saline albuterol on a Q4 8 HRS milligram basis. Asthma and chronic obstructive pulmonary disease 841 MDI 0.37. It's 4-8 puffs. It's 4-8 puffs. Not currently. MG puff. Q20 mins 3 doses. Q mins up. Recommended. Then con 4 HRS with to 4 HRS. Then spacer con per 4 HRs P QR 2 puffs T QR2 puffs T at Q I D P up P R beats 1 2 puffs 5 mins PT2 puffs 5 mins before exercise epinephrine snapshot 110. It's 0.01 mg kg dose. It 0.3 0.5 ng dose. Not currently receptors 1 4 HR snapshot 1 GSML up to 0.3 0.5 mg Q20 mins 3 doses recommended 1 receptors 1 recipe HRS Q20 mins 3 doses 2 receptors inhalation formoterol DPI 12 milligrams. Not currently 5 years 1 capsule 1 receptors 10 12 HRS approved for chronic caps for recommended 1 capsule Q12 HRS 2 receptors. Treatment in inhalation Q12 HRS children 5 years old and for prevention of EIB. In children 12 years old, use at least 15 mins before exercise for EIB prophylaxis. Levobuterol Nebo 6-3 mg 6D11 years QR 0.63 mg TID not currently 1 receptors 6-8 HRs 1.25 milligrams 0.31 milligrams T 1 HRS up to recommended 2 receptors 11 years 1.25 milligrams TID 0.63 1.25 mg 6-8 HRS T P R NDIC. Albuterol dosing continued. On next, page 842, chapter 41I. Pyrberol MDI 0.2. It 4 gate puffs. Q20 at 4 gate puffs. Not currently. 1 receptors. 5 HRs. Thought to be about puff mins. 3 doses. Q20 mins up. Recommended. 2 receptors. Path as potent as then. Corn 4 HRs with to 4 HRs then albuterol on a spacer. Corn 4 HRs. PRN milligram basis. QR2 puffs. QR2 puffs. T I P upon PT 1-2 puffs 5 mins. PT 2 puffs 5 mins. Before exercise. Sometrol MDI 0.025. Not currently. 4 years. 1 poo. 2 puffs. Q12 HRS. 1 receptors. 10-12 HRS. Not indicated. MG puff. Recommended. Puffs. Q12 HRS for acute exacerbations. DPI 0.05 milligrams. Not currently. 4 years. 1 inhalation. 2 receptors take 30-60 mins. Inhalation recommended. 1 inhalation. Q12 HRS before exercise. 4 Q12 HR. DIB prophylaxis. Terbutaline MDI 0.2. QR2 puffs. QR2 puffs. Not currently. 1 receptors. 3-6 parenteral solution. Puff. T. Q. ITP. Recommended. Receptors. Inhalation. Not FDA. Approved. PT. 1 puff 2 puffs 5 mins. PT 2 puffs 5 mins. 1.54 HRS. 4 nebulization before exercise. Parenteral. Snapchat 0.1% at 0.01 mg/kg. 0.25 milligrams. Not currently. 4 8 HRS oral. 1 GVML. Q20 mins 3 doses. Q20 mins recommended. Then Q2 6 HRS P A doses. DPI dry powder. Inhaler. EIB exercise-induced bronchospasm. IT emergency treatment. FDA U.S. Food and Drug Administration. MDI metered dose. Inhaler. Neb solution. 4 nebulizer. QR quick response. PT prophylactic treatment. Snapchat subcutaneous. Adapted from National Institutes of Health. National Heart, Lung, and Blood Institute, National Asthma Education and Prevention Program Expert Panel Report. 2. Guidelines for the diagnosis and management of asthma, NIH, publication 97-4051. July 1997 7-91. Figure 3-5, NIH, R-2, Fig. 35. Table 41-4. Continued, severe acute, chronic, agent, pediatric, adult, pediatric, adult. Site of action, duration of action. Comments. Asthma and chronic obstructive pulmonary disease 843. Hypokalemia may occur in some patients, particularly those receiving concurrent medications that cause hypokalemia, for example, diuretics, amphotericin, and high doses, including inhaled agents. 5. Paradoxical bronchoconstriction found with agonists may be the result of a cold freon effect or the use of additives such as benzalkonium chloride in the formulation. 6. Unlike albuterol, which is a racemic mixture of albuterol's rare and isomers, livalbuterol HCl, oxopenex, is composed of the active R enantiomer. 7. Systemic adverse reactions when the recommended starting dose of levalbuterol is used appear to be similar to or slightly less frequent than the effects of albuterol. When the dose of levalbuterol is increased to 1.25 milligrams, however, the incidence of adverse reactions is similar to the corresponding dose of albuterol. 8. It is important to be aware of significant drug interactions. A. Concomitant use of systemic agonists with monoamine oxidase inhibitors, tricyclic antidepressants, or methyldopa may infrequently lead to severe hypertension. The risk with aerosolized agents may be smaller. Adrenergic blockers, especially non-selective agents as propranolol and carv, dilol precipitate bronchospasm and increase the dose of agonist necessary to achieve bronchodilation. The risk of bronchospasm should be weighed against the potential benefits of blockers. One selective agents such as metoprolol, Toprol XL may be used carefully, for example, in the hospital in asthma patients when the risk-benefit ratio indicates such as in an acute myocardial infarction. C. Agonists should not be combined with other sympathomimetic agents because of additive cardiovascular effects. Vasoconstrictor and vasopressor effects of epinephrine are antagonized by adrenergic blocking agents, for example, phentolamine. The effects of agonists should be closely monitored in the elderly and in patients with a history of hyperthyroidism, diabetes, seizures, arrhythmias, and coronary artery disease. 2. Corticosteroids. Therapeutic effects. Corticosteroids suppress the inflammatory response and decrease airway hyperresponsiveness. B. Mechanism of action. Corticosteroids bind to glucocorticoid receptors on the cytoplasm of cells. The activated receptor regulates transcription of target genes. 1. Corticosteroids reduce inflammation via A. Inhibition of transcription and release of inflammatory genes. B. Increased transcription of anti-inflammatory genes that produce proteins that participate in or suppress the inflammatory process. 2 clinical effects include I. Reduced production of inflammatory mediators. B. Enhanced adrenergic receptor expression, thus making the two agonists work better. C. Decreased mucus production. D. Prevention of endothelial and vascular leakage, partial reversal of tissue remodeling. C. Administration and dosage. When there is no significant difference in the clinical efficacy of the corticosteroid agents currently available. The route of administration is determined by the condition of the patient. Systemic corticosteroids are used for rapid response during an exacerbation. Improvement in pulmonary function may begin within 1 to 3 HRS. However, the maximum effect is not achieved until 6 to 9 HRS or longer after administration. Supplemental doses should be administered to patients who are already taking systemic corticosteroids when they experience an exacerbation, even if the exacerbation is mild. 3. Intravenous corticosteroids, for example, methylprednisolone solumedrol, are administered to patients who are unable to take oral medications in severe exacerbations. Large doses, for example, methylprednisolone 60 mg or 125 mg intravenously, are quickly administered. However, patients can usually be switched to oral therapy as soon as they show clinical improvement and can tolerate oral medication. 844 Chapter 41I. Oral corticosteroids are acceptable as emergency treatment if the patient can tolerate the oral route and is not believed to be in imminent danger of respiratory arrest. Prednisone and prednisolone, Prelone, are the most frequently used oral corticosteroids. Prednisone and prednisolone are frequently administered in short bursts over 3 to 10 days. To treat exacerbations in the outpatient setting and in the emergency department. This type of regimen may also be used to rapidly achieve asthma control. During burst therapy, these agents may be administered for 3 to 10 days in 1 or 2 daily doses and then discontinued. When used in this fashion, tapering is not usually necessary but is often done by physicians. However, if a patient's condition appears to worsen after the last dose has been administered, it is reasonable to reinstitute the corticosteroid and then begin a tapering regimen. 5. Because inhaled corticosteroids are least likely to produce adverse reactions, the inhaled route should be used whenever possible for chronic treatment. Inhaled corticosteroids should not be used alone to treat serious acute exacerbations. B. Inhaled steroids are the preferred anti-inflammatory therapy for chronic asthma. C. In milder outpatient flares, doses of the inhaled steroids may be increased temporarily, although this is controversial and should not be done if in a combination inhaler of Xlaba. D. The number of corticosteroids available for inhalation therapy is increasing. The most recent additions are mometasone, Osmanex, and cyclizumide, Alvesco. Dosages of inhaled corticosteroids are provided in Table 41-5. When asthma control is achieved, attempts should be made to use the lowest effective dose to maintain. Table 41-5 estimated comparative daily dosages for inhaled corticosteroids. Low daily dose, medium daily dose, high daily dose. Drug in adult child, adult child, adult child. Beclomethasone, CFC, 42 or 84 grams, puff, 168, 504 grams, 84, 336 grams, 504 grams, 84, 336, 672 grams, 840 grams, 672 grams, HFA, 40 or 80 grams, 870, 40 grams, 240, 480 grams, 160, 320 grams, 480 grams, 320 grams, budesonide. DPI, 200 grams inhalation, 200, G 200 400 grams 600 200 grams 600 200 grams. Inhalation suspension 0.5 milligrams 1 milligram 2 milligrams. For nebulization, child dose flunicillide 250 grams puff 500 1,000 grams 500 750 grams 1,000 grams 1,000 grams 500 grams 500 grams 5 1,250 grams fluticasone. NDIB 44 110 or 88 264 grams. The 88 176 grams 264 660 grams 176 440 grams 60 grams 460 grams 160 grams. DPI 50 100 or 100 300 grams 100 200 grams 300 grams 100 grams 200 grams 100 grams 200 grams 400 grams 250 grams inhalation mometasone. DPI 200 grams inhalation 200 grams NZA 400 grams ND 400 grams ND. Not approved for persons 12 years old. Triamcinolone 100 grams puff 400 1000 G 400,000 grams 2000 grams 800 grams 200 grams 2000 grams 1000 200 grams. In all cases, the lowest dose to maintain control should be used. Some doses are outside package labeling. BMDI doses are actuator doses. That is, amount leaving actuator. CFC, chlorofluorocarbons. DPI, dry powder inhaler. HFA, hydrofluoroalkanase. MDI, meter dose inhaler. Modified from National Asthma Education and Prevention Program Expert Panel Report Guidelines for the Diagnosis and Management of Asthma, NHLBI Asthma Guidelines 2007. August 2007. Asthma and Chronic Obstructive Pulmonary Disease 845. Control. Step-down therapy. Side effects of inhaled steroids and systemic steroids are dose-dependent. Inhaled corticosteroids are considered first-line anti-inflammatory therapy for mild to severe persistent asthma in both adults and children. 6. Treatment of asthma exacerbation in adults. A. For treatment of a severe exacerbation, prednisone may be given at a dose of 2 mg/kg, maximum of 60 mg/kg.